We look after breast cancer patients really from diagnosis through to death, and we work along with a good team of consultant colleagues. We've developed nurse-led service on a sort of drop-in basis for many of our patients who experience problems of pain, new lumps, any concerns that they have, and are able to see them ourselves and decide upon what investigations or treatments that we can advise on them in that stage.
So I suppose you've answered a bit of the question. How was the need identified that you needed a nurse-led clinic service? And I know we've debated off camera about the idea of nurse-led clinic, but we can perhaps talk about that. But I'm just thinking how the need was identified for the service to be set up.
I think it was really the fact that it was difficult trying to get medical staff to see the people in a timely fashion, that the clinics that they run are always very full. You know, if you wanted a follow-up appointment, it had to be kind of 3 months or 4 months till there was a space. Even in the times when they were seeing people immediately after surgery, these clinics were very busy as well. And so we thought, well, we could develop the service ourselves so that we could see the people, and if it was something that we couldn't particularly deal with, we could then pass it on to a doctor if necessary. But with time and experience, that we can actually deal with most of the things that the patients are now calling us about.
So in setting up the service, Avril, was there what were the challenges behind that? And, you know, things that you found were easy to do and things that were a challenge to the team?
Challenges are always in relation to one's secretarial support. A lot of the objectives that we currently manage and the patients that we see is a lot of it's last minute. Again, it's patient demand. They're not necessarily booked in advance. They could phone us the morning of. And we've had this debate about having notes, you know, obviously having access to systems, and you just can't because of the demand, obviously, of the service. We've got good support with each other, and our own nursing records are there that we can obviously refer to. But again, for the high volume of patients that we see, it's, you know, there is obviously, you know, a lot of restrictions on what we do achieve.
So this idea of nurse-led clinic, no it isn't, yes it is, etc. How does that, can you tell us a bit about that debate? Even if there is a definition of a nurse-led clinic, what do you define it as?
I think, could I answer that by saying what I think other people sometimes define a nurse-led clinic, when you actually have planned, booked appointments, and you have a set of notes, and you go to a clinic area and patients know that they're coming. I think that's all people think of as being sort of nurse-led clinics in the kind of perhaps the more traditional way. And I think we do ours and we're responding to the patient needs, and yes, there are drawbacks, as Avril said, is that we don't necessarily always have the notes but we still do document, but we see the patient, so I think we provide a good service from that point of view. Another part of our role is that we do follow-up clinic, and we run our clinic alongside the medical staff, and it's just you pick up the next set of notes that's available. Now that is an organised follow-up clinic where patients are seen either every 6 months or every year following their treatment, but we don't pick and choose, this is one for the nurses, this is one for the doctors. It's, we pick up the next set of notes that's there, and if we know the patient, then that would be the one you would take for continuity for the patients. That, I suppose, some people might class a little bit as being more the medical model of follow-up, but I think we bring our expertise as breast care nurses to that clinic rather than necessarily the skills that the surgeon or the oncologist might have.
Would you want to add to that, Avril?
I think Gillian actually did that very well. But I do absolutely passionately feel, you know, as you say, the nurse-led clinic title, and I'm much more into team effort, you know, joint care. Because, again, as nurses we bring a lot, but let's not forget we're medical colleagues, and I think we should be looking at shared care.
Was that a model then that developed naturally, or that you both felt I'm passionate about, this is the way it should be?
I think it developed naturally, to be honest, but as we started to be trained by our colleagues to do follow-up and breast examination, and we knew the things we wanted to ask the patients about as to how were they coping, how were they getting back on with their life following their treatment, but we had to do the kind of the breast examination aspect which we were taught. But as we became more involved with it, I think we became more passionate about the what a nurse can bring to that clinic as well.
I think it has to be credit to our medical colleagues. We are very fortunate to work in a very close team of breast surgeons, breast oncologists, who I truly believe value our input and allow us to decision make, plan care for the patient, organise scans, do tests, again with very little resistance, because I think of the specialist knowledge that we have managed to demonstrate. And I think we're very fortunate to compare with speaking to some other of my colleagues who, again, medical staff keep much more a check on perhaps what's being done. So again, it's not even nurse-led, again it's been autonomous and right decision making, but again with support, mutual support, because they value our opinion as we value theirs.
Yeah. I mean, how did that happen? Is it because of the people you are, or is it because of the people they are? I mean, why do you think you haven't particularly? I mean, have you known them for years?
I think that's partly what it is. I mean, I when I came into post, it was the surgeons who wanted a breast care nurse, and the oncologists didn't really see where I fitted in into their team, because they thought they did everything. They spent the time with the patient. They gave all the explanation and all the support they required. So just with getting to know each other and learning as what a nurse could do within the team, sort of they came on board with us, and now they're the first people to email us, send stuff in the post, or phone us when they're looking for assistance or help. So it's taken time to do it, but I think it's been mutual respect for each other and recognition of the differing roles that we have that can come together to create a good service.
Just following on from what Gillian's saying, I think that it's part of getting to know each other, but a part of getting to know each other is how you read what that colleague of yours is going to do when they decision make. And I think we know each other well enough now without having standardised care, because we do very much individualised care. But looking at scan results, looking at blood results, looking when we see patients, we will often be the ones who will break the bad news in cases where unfortunately the cancer is spread. But again, the trust has been allowed for us to put that forward, knowing that what our colleagues are going to say to them, perhaps when they see them under medical management clinics.
I think we also work as breast care nurses very closely together and support each other, so that we can discuss patients as well and think, well, what do you think we would do this one, or do you think I should do this, and that's been extremely helpful over the years as well, because that gives you confidence with what you're doing too.
I mean, have you had any head-to-heads with the? Has it all been a bed of roses, or has there, been any tension?
No, I mean, I think there are times when you perhaps don't necessarily always agree with a decision that somebody else makes, but you respect them because we're professionals, and the medics can change. One consultant will say one thing one week, and somebody else could have a similar scenario a few weeks later and make a different decision, and neither of them are wrong. So although you might have a gut instinct about what you would quite like for the patient, because you sometimes think you know them better, but you respect their professional judgment.
And we hold very good multidisciplinary team meetings once a week, which we're very fortunate to have, and it is a well-run, identified session, which we have the opportunity to often discuss many of the patients, and again, disagree with each other. That's good as well, because then we're all having different ideas what's best for the patient, including them in their care.
In terms of evaluation, how you know that your service is effective and beneficial to the patient, tricky, because you're not completely nurse-led, I presume. You're not completely. How do you evaluate this service when it's kind of blurring with multidisciplinary colleagues?
We haven't done any sort of formal audits or patient questionnaires. I suppose we go on what the patients tell us as to what they've liked and what they haven't liked. We are about to start looking with breakthrough breast cancer at a service pledge, and I think sending out questionnaires will probably generate from the patients being treated at the moment quite a lot of information for us that we can look at taking that forward as a part of an evaluation of all aspects of the service.
And again, it's all down to what we now have to formally assess to prove your worth, which a lot of nurses obviously feel with nurse-led, and a lot of our work is unplanned. The patients that we will see in our own clinics, I say, is unplanned, often last minute, it's often urgent. And I can honestly say that where patients have never disputed at the time that we see them, and we can always, there's never really been a time we can't fit them into a clinic that day. And again, what Gillian started off by saying, that's where the need for the service came. And we actually changed our working hours to fit in with longer days, so that if patients did phone early or late, that we can fit them into one of our clinics so that we can see them. So Gillian's absolutely right when we say a lot of the feedback is from the patients, but I appreciate that we will need to change, I suppose, for the future.
Is there any final thoughts for nurses around the world, almost not just the UK, setting up this kind of service that you could pass on as sort of final tips?
I think with our service, you actually don't often know what that patient's problem is going to be coming through the door, and that somebody can phone and say, could you have a wee look at my wound, I'm a bit concerned about it. In actual fact, that was their excuse to come. And what you thought might be a quick 5-minute look at a wound and maybe some antibiotics or some dressings turns out to be an hour, because they're really struggling to cope, and that was really the reason that they wanted to come. So sometimes what somebody can phone you about, so you don't ever always know the level of intervention that you're going to have to give to patients, either at the drop-in nurse-led clinic or even at the follow-up clinic, because you could read a previous letter and think, oh, this patient will be absolutely fine, no problems, they're coming towards the end of their follow-up, that will still be a quick in out. But no, that can be the one that can take you much longer than any others to do.
I would probably like to add to that I think of what we do in our service is it's nursing. You know, and we've never lost the value of what we do with our patients, that although we can make medical decisions, order scans, interpret results, obviously plan care for patients, that again, Jill said, you know, a lot of when they come to see us about one thing, it will lead on to other things, and we haven't lost the value of nursing, which I feel quite passionate about, because a lot of nurse-led clinics have gone into practitioner roles and gone into expanded roles, whereas they're actually not nursing roles anymore, and we wouldn't want to lose that.
Okay, thank you both very much.
Thank you.